Okay, thank you very much. I think I have something to work with. The slides were created with Debbie Larson, my head hand therapist. Splinting confers no benefit. Leave your prejudices aside, clear head, there is some science to this. We like the concept of an adjunctive therapy to our surgery because surgery has a high recurrence rate. We want something else. Splints, piece of thermoplastic, lovely, easy, no negative effects. Well, let's try and put some science to it. So let's use our heads over our hearts on this one. We know for some laboratory data, if you pull on fibroblasts, myofibroblasts, they pull back all the harder. I know it's only a laboratory model and it may not apply so much clinically, but it's an interesting thought that the fibroblasts might not like an increased tensile environment. But what about non-operative splinting? So splinting, for those who weren't considering surgery, can we use them? There's really only one paper, and I'm very cognizant that the people who wrote these papers may be here today, so I hope I get them right. And this is the Salgado paper from the London, Ontario unit. Now, they used a nighttime splint, but note, exercises as well, friction massage, and you've seen Wolfgang refer to the patient survey, some people really feeling that helped them. There were 13 patients with PIP joint contractures, and over a mean of around a year, they saw some improvement around 15 degrees, and perhaps some qualitative changes as well. So a concept is that if you have a very motivated patient who's going to comply and use the splint, if there's a bit of mild and moderate contracture, it may be that a splint might improve your contracture a little bit. But we don't know the effects of stopping that splint, and look at all the other therapies the patient was getting. You had a splint mixed up with all those other things that the hand therapists do for your patients. So what about surgery? Come on, splint must help. I always ask my therapist for a splint. There are 3 randomized trials now. First, the SCORED study, which we performed in East Anglia. We were quickly followed by Judy Collis with the same protocol. And finally, Chemla from this great institution, I think. So nighttime splinting, what did we do? We simply added or removed a nighttime splint to normal hand therapy practice after surgery. We had 154 patients and randomized them preoperatively. The night splint was on for 6 months, and they had a year follow-up. Somebody drove round to all their houses. Now, the study has been criticized because we had some crossover. At that point, ethically, because people had been splinting, we couldn't deny patients a splint if we felt they were recontracting, because that's what people do. So we built into our study that if they were coming down by 15 or 20 degrees at the MCP or PIP, they could be crossed over. But the analysis was under an intention to treat principle. Of course, they got all the other stuff. It's just the night splint. So we had 13 people cross over. 8 because surgeons were a bit sort of scared, and they said, oh, we'll have a splint anyway, although there was no evidence of recontracture. So in other words, we had 17% people cross over. But look at our scores. DASH, okay, we can accept now, perhaps not such a great tool. But look at our active extension in the 2 groups. No splint, splint. No statistical significance. Satisfaction high. The adherence to splint was good. So we can conclude from SCORED that you don't need to put splints on everybody at night. You can wait and see, and it's perfectly safe, if you need to, for a small group to put a splint on. So Collis comes along, and she uses the same methodology. A slightly smaller study, a night splint for 3 months. She has 3 of her patients who cross over. And look at her results. Hand therapy only, 33 degrees. Better than the splint group, although that's not statistically significant. High patient satisfactions, perhaps higher with hand therapy alone. Patients are trending towards liking not having to have a splint. So there's no significant difference. Wait and see. Splint the 10%. Finally, the Chemla study from Groningen. So we've got, this is harsher. There ain't no crossovers in Holland. They do things properly in Holland. None of this wishy-washy crossover ethical stuff. All right? They've got a splint on. 4 weeks full-time, then night 3 months, or just hand therapy. Look at the results. Hand therapy, better, although actually no statistically significant difference. PIP joints, little fingers, the feared territory. So the conclusion from the Chemla study is there is no difference at all between splint and no splint, but they are receiving hand therapy. So in conclusion, there is one paper that evidences a little bit of an improvement using a splint with other adjunctive therapies for a non-surgical intervention. But post-surgery, there is no evidence to support the addition of night splinting to routine hand therapy practice. Note the distinction. Now, 10 or 17% of patients will recontract. We don't know who, we don't know why, we don't know what will help them. But traditionally, we used a splint, so traditionally, we pop those patients back. So I put it to you, this is head over heart. All right? The science says no. Thank you.